I hope and I believe all of you are doing well. A quick nod whether the audio visual is all good. So I'm facing some network issues on my end. I hope we are able to run through this session. All right, I hope I'm audible and visible to everyone. So, happy morning, everyone. Today, we are going to discuss the top 10 radiology images related to infectious diseases. Right, these are very, very important. I have handpicked some most important infectious diseases images that you should be knowing. And the plan for the rest of the day today is after this session, like this is for half an hour. After that, immediately at 10:15 a.m., we would be having open house session like every day we are having after the YouTube session. So it's on the Unacademy app. It's a free session open house for the students who are new here. It's basically a podcast or an audio interaction where you can connect with the educator and you can ask your queries as well. So that is like an audio call. 5 p.m. we have the KBMD like we have every day, Kaun Banega MD. Yesterday we had fast 5 clinical questions. So today we have top 10 mnemonics. Again, this is on the app. It is free for everyone. While enrolling, if you are asked for a code, you can use the code Dr. Nikita. Okay. Then 8 p.m. we have the plus course, radiology PYQs today and tomorrow. That is 11th and 12th, 8 to 10 p.m. All the radiology PYQs, which are very, very important. And we have your FMGE, NEET PG, INICT, all the PYQs would be discussed. So this is for the subscribers. Okay, this is for the subscribers. All right. And we have started with the new batches recently for all the exams, including INICT exam. We've started with a new batch, 2 month revision course. We've also started with MCQ marathon batch. For FMD students, again, there's a 2 months batch. So all the students, please make the best of these batches. These are for the subscribers. And there's also this all educator revision batch, which is going on, where you would be having revision classes. Then you'll be given break for self-study. Then you will have a test. And again, there would be a discussion. So basically, everything is covered in this course where you have the theory discussion, you revise that, then you give a test and you have a discussion for the test. So everything is included in that. In this course, we have radiology on 27 March. All right. Okay. These are the subscription plans that we have for Plus and Iconic. The minimum duration is 3 months for Plus, right? So whenever you are subscribing using the code, it can help you get additional discount. Okay. All right. So let's start with the top 10 infectious diseases. Tell me the first one. What do you think is the first image showing? What infection is this? So let's correlate all the images, image A, image B, image C, and the image D. Yes, absolutely right, Srashti. This is basically tuberculosis. So what are we seeing in these images? Let us see one by one. So this is MRI with the black bone cortex. This is contrast MRI, where we see this multiple ring enhancing lesions, right? There are these ring enhancing lesions, central necrosis, forming a conglomerate sort of lesion. There are these other ring enhancing lesions also in the brain. So conglomerate ring enhancing lesions like this, you should think of tuberculosis. What complication of tuberculosis are we seeing in this image? What complication of tuberculosis are we seeing here? So these are the lateral ventricles which are dilated. So there is hydrocephalus, which is a known complication with tuberculosis causing meningitis leading to hydrocephalus. All right. What are we seeing in this image? What manifestation of tuberculosis are we seeing here? So all this which you see here in the contrast scan, this is the shaggy, the dirty enhancement of the meninges of the cisterns on the contrast scan. So this is your this is your meningitis. This is how meningitis looks like. That is this dirty, thick enhancement that we are seeing. So that is meningitis basically, right? Basal exudates, meningeal enhancement. Again, there is this hydrocephalus. These are the temporal horns of the lateral ventricles which are prominent. And this is very, very important as in one of the recent AIMS exam also. This is basically MR spectroscopy. And in MR spectroscopy here, we are seeing this peak, right? Where is the peak? Between 1 to 2 ppm. That is approximately at 1.35 ppm. If you see the peak, that is the lipid peak. So please remember that. Okay. Uh, Please remember that it is your lipid peak that is seen with tuberculosis. Why lipid peak? Because TB mycobacterium has that mycolipid wall. Okay, so this is the first infection that we have seen, that is tuberculosis. This is your lipid peak at 1.35 ppm. Okay, remember, very, very important. Going to the next image here, what do you think are these images showing? Okay, ppm slash T. So in the MR spectroscopy, if you look at this image, this is mentioned ppm, so based on at what ppm you are getting a peak, we identify what chemical it is. Now here we are getting the peak in the spectroscopy at around in between 1 to 2, 1.5 se bhi pehle, that is 1.35 approximately. At 1.35, if you get a peak, that tells you it is a lipid, which is the component there. Okay, so that is the lipid peak. All right. Okay. What do you think are these radiographs showing? What are these? Yes. So again, the continuation of tuberculosis, the chest X-ray findings basically, which are very, very important. What do we see in the first image is, in this chest radiograph, in the right upper zone, we see this lot of, the dirty, dirty white strands we see, right? So those are basically the fibrotic strands that we are seeing. There's this patchy opacification, right? And you can also see that the trachea is getting pulled towards that side. That means there's a component of fibrosis, there's a component of collapse, which is pulling the trachea towards itself. So that is your classical tuberculosis, right upper zone, very, very commonly involved. There is this hilum, which is bulky as well, right? The hilum is also pulled up, right? The hilum is also pulled up. Normally, the left hilum is higher. So this is the classical image of tuberculosis. What are we seeing in this image? These are those tiny, tiny shadows that we are seeing here. That is miliary mottling, right? In a patient of TB, this is miliary TB. But remember that miliary mottling is not always TB. Okay, it is not specific for TB. It can be seen with TB. The occupational lung disease, which is similar to TB, is silicosis. It can be seen with fungal infections, histoplasma, blastomycosis, a lot of them. It can be seen with your miliary metastasis, right? Miliary mets can also occur. Thyroid carcinoma can give miliary mets. A lot of conditions, again, pulmonary hemosidrosis that can give, okay? So that can give your miliary mottling. Remember that miliary mottling is not seen with Klebsiella pneumonia, because basically it causes lobar pneumonia. Okay, it is not seen with PCP. These are the previously asked questions. It's not seen with pneumocystis. With pneumocystis, we see the bilateral perihilar ground glass opacities. Right, very good. This miliary mottling can be seen with healed varicella infection as well. Absolutely right. Okay. So that was about TB. Going to the next infection. What do you think is this infection here? Correlate all the three images and tell me what do you think is this infection which is represented here? Very good. That is NCC. So why do you call it NCC? Absolutely right. So what are we seeing here is, first of all, this is very, very important. In the brain, we are seeing this multiple calcified lesions, right? There are these multiple calcified lesions. The gray matter, white matter interfaces involved. This is called as what appearance? Anyone? What is this appearance called as? These white scattered lesions, those are like the stars. That is called as starry sky appearance, right? That is the starry sky appearance, which is basically seen with neurocysticercosis. What are we seeing in the second image? What are we seeing in the second image here? So here in the second image, if you see that it's a cystic lesion, CSF density, there's a dot inside, that is the scolex. There is a cystic lesion with a dot inside. So that is basically showing your scolex of tinea solium. So this is a cyst with dot. That dot represents the scolex of tinea solium. So this is actually your neurocysticercosis, right? A cystic lesion in the brain with the scolex, neurocysticercosis. Okay. And what is this third image showing? This is interesting. What are we seeing here? These are the calcifications in the soft tissue, in the muscles, along the muscle fibers, right? These are the calcifications. What are these calcifications called as? These are like the rice grain, right? They look like the rice grain. So that is the rice grain calcification. Okay, rice grain calcification is suggestive of cysticercosis. Okay, that's your muscular cysticercosis. Okay. So this is about neurocysticercosis, muscular cysticercosis. Remember, you can get in the eye also. Okay. Next one, identify this infection. This is the third infection here. What do you think is this infection here? If I give you a clue that this patient is an immunocompromised patient presenting with fever and seizures. Absolutely right. This is toxoplasmosis, which is showing what sign? This is the ring enhancing lesion, and inside that we are seeing another ring, but that ring is not in the center. It is eccentric ring. So this is basically called as eccentric target sign. Okay, this is called as eccentric target sign. Okay, this is the eccentric target sign, which is seen with toxoplasmosis. Okay, which is seen with toxoplasmosis. So ring enhancing lesion with an eccentric target. Normally the target sign is one circle and another circle. That inner circle is in the center. Here it is in the periphery. So that is the eccentric target sign seen with toxoplasmosis, which is an opportunistic infection, immunocompromised patients is what it would be seen with. Okay. Yes, congenital toxoplasmosis. Remember T for throughout, it shows calcification throughout. Okay, in congenital toxoplasmosis. Next one, the fourth infection. What do you think is this infection here? What do you think is this infection here? Look at the location, look at the lobe which is involved. Which lobe is showing the altered signal intensity? Very good. That is the temporal lobe. Again, this is the temporal lobe showing the altered signal intensity. It could be unilateral, it could be bilateral. So this is herpes simplex virus encephalitis. Please remember this important point that it has a predilection for temporal lobe. It's a very important question. Temporal lobe, HSV encephalitis. Along with the temporal lobe, the adjacent, this is your frontal, the basifrontal lobe can also be involved, right? The basifrontal lobe can also be involved, and the drug of choice in this case would be acyclovir. Okay, so please remember HSV is temporal lobe. Very, very important. Okay, HSV is temporal lobe. Going to the next infection here. What do you think is this infection which is depicted here? All these images put together, what is this? Absolutely right. So all these are the images of hydatid cyst. What is hydatid cyst caused by? Echinococcus granulosis. Okay, it is caused by Echinococcus granulosis. So what are we seeing here in the first image in the chest radiograph? There is a lesion which is showing this fluid in its dependent part, and on the fluid we are seeing there is something floating there. Right, on the fluid, there is something floating there, which is the water lily, which is basically the ruptured membranes. Right, so that's a water lily sign of hydatid. This is on ultrasound, black fluid. This is the black fluid on ultrasound, cystic lesion. Again, the water lily sign on ultrasound, that is the ruptured membrane floating. On the CT scan, again, like we saw in the chest radiograph, there is a lesion, air, fluid level, and in the fluid, we see those some membranes which are there, which tells you it's a hydatid cyst. Here on ultrasound, we are seeing a mother cyst, a badasa lesion with multiple daughter cysts. Those are the tiny, tiny daughter cysts within. So that is your mother cyst with multiple daughter cysts. Right. So all this basically, this is the water lily sign. Okay, that's the water lily sign. Again, a very, very favorite question for the exam. Right, this is the mother cyst with the multiple daughter cyst. Okay, so that is basically your cyst within cyst appearance. Right, within the mother cyst, we have multiple daughter cyst, also called as honeycomb or rosette pattern. All right. So this is a hydatid cyst. Investigation of choice is ultrasound to look for the cystic area, whether it is cystic or not. Ultrasound helps us to identify that. If particularly the question is to look for calcified hydatid cyst, calcification ke liye, it is CT scan because hydatid undergoes calcification. Okay. So very, very important. Please remember water lily sign is hydatid cyst. It is the ruptured membranes floating. Okay. Next one, the sixth infection here, right? Now we are mostly seeing the chest radiograph. We have abdominal ultrasound also. What is this? What are we seeing in this radiograph? What are all these? Okay, what are these thin walled rounded areas? This thin walled rounded areas that we are seeing basically? No, this is not CDH, Reva. In CDH, right, you will see the multiple bowel loops within. We are seeing the diaphragm here. Well, right, the diaphragm is seen here. Very good. Very good, Julie. Absolutely right. So this is basically black colored cavity that you are seeing, right? There are these cavities, black colored, black means air. So these are basically pneumatoceles, right? These are basically pneumatoceles. Most commonly, pneumatocele is seen with staphylococcal infection, right? It is seen with staphylococcal pneumonia. Might be seen with others also, like Haemophilus Klebsiella, but the most common is staphylococcus. Second, pneumocystis, as the term itself tells. It is pneumocystis. So PCP can also show the pneumatoceles. Okay. So remember, these are pneumatoceles. They might contain a small amount of fluid as well, but they have the thin wall, while an abscess, which also has air fluid level, it is more thick walled. These are thin walled. Okay, pneumatoceles are thin walled. So this is pneumatocele. Next one, right? Very, very important and a very potential question for your exam. What do you think is this HRCT showing? All right, so the network issue has creeped in again. Yes. Let me try reconnecting, guys. Is it working fine? I think it is working fine now. Okay, absolutely right. So this is basically COVID-19 in the present scenario. This is what we should know. So what is the CT scan showing? Basically, if you have a look at the CT, this is ground glass opacity, right? This is ground glass opacity. Now, why is this ground glass opacity? Why is this not consolidation? The difference is through the ground glass opacity, we can see this vessels traversing, right? You can see the vessels passing through it. That means it is not completely white. So that is your ground glass opacity, bilateral, peripheral. It's in the periphery subpleural. This is classical for COVID-19, right? Bilateral, peripheral, subpleural GGOs. This was asked in the recent FMGE exam. What is the most common HRCT finding with COVID-19? It is bilateral, peripheral, subpleural ground glass opacities. Remember, it's not specific for COVID, but this is the most common finding in COVID. We see a lot of other features also in COVID, like the crazy pavement. We see the atoll sign, reverse halo sign, the halo sign. There are multiple other signs which are seen. Okay. Going to the next infection, that is your infection number 8. What is this infection which is shown here? So what are we seeing here in this right upper zone? There is the opacification, and this is the horizontal fissure. The horizontal fissure should be horizontal like this. The fissure has bulged down. So this is basically bulging fissure sign. Okay, this is bulging fissure sign. And what commonly gives the most common cause of this bulging fissure sign is Klebsiella pneumonia. Okay, basically it is Klebsiella pneumonia which is the most common cause. Klebsiella friedlanders bacillus, it gives your currant jelly sputum, right? It gives the currant jelly sputum. So sputum which is very, very thick, viscous, right? That causes the pressure on the fissure. So that is the bulging fissure sign, okay? This is not the golden S sign. Golden S, as the term says, it will be like this. It will be like a S, golden S. There's a collapse. The fissure is pulled up. Here the fissure is pushed down. It is the bulging fissure sign. Okay. So this is most commonly Klebsiella pneumonia. Okay, Klebsiella pneumonia. Going to the next one. What do you think is this infection here? Look at all the images. One sign has also been labeled. Yes. So basically, this is your fungal infection that is Aspergillus. Okay, this is the fungal infection that is Aspergillus. So what are we seeing here is this is ABPA. ABPA, classically, it causes your central bronchiectasis. The large bronchi, the central bronchi are dilated. So these, like which you see here, these are the dilated bronchi. Why are they not black? Because they are containing mucus. Allergic, a lot of mucus production. So allergic bronchopulmonary aspergillosis, allergic mucus production. The bronchi are dilated and filled with mucus, right? So this sign is called as finger in glove sign, right? It is your finger in glove sign. The fingers are the bronchi, glove is the mucus which is filling the bronchi. Similarly, here in this first image, all this which you see here, all these are the dilated bronchi filled with mucus. That is why they are white. You can see some tree in bud also in the periphery. There is the tree in bud also, which can be seen with aspergillosis. It can be seen with TB as well. Okay, so that's a tree in bud plus you have the finger in glove sign. Look at the mediastinal soft tissue window. All these are the bronchi. These are the fingers that you can see. These are the finger-like projections which are filled with high attenuation mucus, right? That is your ham sign. High attenuation mucus is filling up the bronchi. This is the finger in glove sign. Okay, this is the finger in glove sign. What is the next sign that we are seeing here? The monod sign. Monod sign is seen with aspergilloma. Aspergilloma means a fungal ball. So basically in a cavity, in a pre-existing cavity, a fungal ball comes and sits. So what happens is in the cavity, you will see the fungal ball. That's occupying the majority of the space. Above the fungal ball, we have this crescent of air, right? The black color is the crescent of air. So this crescent of air, that is called as monod sign. Okay, so this is basically seen with aspergilloma. That is the fungal ball. Okay, that is aspergilloma. That is the fungal ball which is showing this monod sign, air crescent sign, right? The air crescent. Basically, air crescent is used for healing wale part mein, but sometimes it used interchangeably as well. So monod sign, right? It is the monod sign or the air crescent sign. What sign do we see in angio-invasive aspergillosis? Angio-invasive aspergillosis gives the halo sign. Okay, that gives the halo sign in angio-invasive. All right. Coming to the last infection here, the top 10, this is the 10th one. What infection do you think is represented here? नहीं, सृष्टि high attenuation मतलब X-rays ज़्यादा रोक पा रहा है absolutely. So because it is not allowing the X-rays to pass through it, like the bones which do not allow the X-rays to penetrate, pass through it, the bones look white. Similarly, this mucus is high attenuation. It's stopping the X-rays, not penetrating. That is why it looks white. Okay, that is why it looks white. Absolutely right, Ravi. That is your viral, acute viral hepatitis to be specific. Okay, this is acute viral hepatitis. This is a previous FMGE question. Why do we call it acute viral hepatitis? Look at the liver here. Okay, this is the liver on ultrasound. These white are the portal venules, the portal radicals, which are looking very white because the liver has become dark. So in acute viral hepatitis, because of the edema, the liver becomes dark. So the portal veins, they look very white. This is called as starry sky appearance. So a previously asked question, so important. Starry sky appearance on ultrasound is seen with, remember it's acute, not the chronic, acute viral hepatitis where there is a lot of edema, so the liver has become dark. So that is acute viral hepatitis, starry sky appearance. All right. So these are the top 10 infections that we have seen. A quick review. First one was the TB. Remember conglomerate, ring enhancing, hydrocephalus, meningitis and lipid peak. Second one was cysticercosis, starry sky appearance, cyst with dot and rice grain calcification. Then we had eccentric target sign, toxoplasmosis, temporal lobe, HSV encephalitis. Then we had the water lily sign, cyst within cyst sign, hydatid cyst, pneumatoceles, staphylococcal and PCP pneumonia, bilateral peripheral subpleural GGOs, very common in COVID-19, a very important question. Then we had the bulging fissure sign, that is Klebsiella pneumonia. And then we have finger and glove sign, monod sign, that is seen with Aspergillus, which causes central bronchiectasis. Remember central bronchiectasis. And then we have the starry sky appearance, which is seen in acute viral hepatitis. Okay, acute viral hepatitis. So these were the top 10, very important. Each one of them is a potential question for your exam in infectious diseases, right? So now immediately after this, we'll be starting with the open house, which is Ask Me Anything session. Whatever queries you have related to your preparation, please feel free to ask, and there would be a tint of motivation as well in that session. When are we meeting after the open house session? 5 p.m. KBMD, top 10 mnemonics, mixed bag mnemonics, very high yield. KBMD is Kaun Banega MD, a live quiz with leaderboard. It's a free class. Unlock code is Dr. Nikita. 8 p.m. plus class, radiology PYQs today and tomorrow, 8 p.m. to 10 p.m. Okay, that's what the plan is. All right. So that's about this. Dr. Sadaf class on orthopedics important test. I'll try and take it very soon. And Reva, I've already taken a class on COVID, though not integrated, the radiology aspect of it. I'll post a PDF of this class, the annotated PDF on the Telegram group. You can fetch it from there for later revision. Okay. Thank you so much, everyone. Let's meet.